Hello and welcome to this webinar in our series looking at issues around suicide prevention. Thank you for joining us this afternoon. Today's webinar is focusing on the impact of the death of a patient by suicide on staff. Most people listening to this webinar will be mental health clinicians, and we are all very used to working with people who may struggle with thoughts of suicide and suicidal behaviours, and some of us will have experienced, sadly, the death of a patient by suicide. So it's really important for us to think very carefully about what impact that has and how we can support our staff, and that's what today we'll be looking at. We've got Guy Harrison, who's our head of Pastoral Care and Staff Support, chairing the event, and he will go on to introduce our two speakers. So I will hand over to Guy in just 1 second. I guess the first thing I'd like to say is, you know, as we've talked about previously, just be mindful that this is the best time for you to listen to the webinar today if you have recently struggled with you know, experiencing the death of a patient by suicide or working with somebody that you think is at risk. Make sure you get the right support. There is support out there that we'll talk about later. And if you feel that now isn't the right time to watch this webinar, it will be on the internet and it will be recorded for you to watch at a later date. Thank you. So I will pass on to you, Guy. Thanks. You're muted, Guy.
Thanks, Karen. It's not an easy subject to talk about, death by suicide, and yet it's vital if we're to understand how best to support our staff. Suicide and attempted suicide teach us, or touch us, I should say, all of us, and can be personally and professionally very incredibly devastating. Along with the support my colleagues and I seek to offer staff, I've seen for myself the lifelong and often harrowing impact that death by suicide can have. Many years ago, the death of a close colleague. Some years later, working as a hospice chaplain, the violent death of a member of staff on the premises, which had a profound shock on individuals as well as a small organisation. And finally, and more recently, the death of a young patient I was seeking to support. Feelings of failure, guilt, anger, and sometimes overwhelming sadness that I needed to understand, and with support, process, and memories that I feel sure will be lifelong. Uniquely in the NHS, mental health services are predicated on the fact that in order to support patients on their journey to recovery, as clinicians, we need to be able to establish an ongoing therapeutic relationship. Treatment involves seeking connection, empathy, and the holding of hope. And when things go well, that critical work, the management of risk, can be immensely rewarding. When one of our patients dies by suicide, it can leave us feeling as if we've failed, or as if somehow we weren't good enough, that we weren't able to hold that hope. Vicarious trauma can become a reality, affecting us physically, emotionally, spiritually, affecting our work, our home life, and the team of which we are part. Thankfully, the awareness of the need for support and for so long missing is becoming more of a reality. And the right support at the right time is vital if we're to support staff health and well-being. So for today's webinar, I'm looking forward to hearing first from Rachel Gibbons, a consultant psychiatrist, who will share her experiences of the impact of death by suicide. And then from Alison Croft, a consultant psychologist at Oxford Health, who will present some recent research which asks clinicians about their experiences and their perspective on support. So over to you, Rachel.
Hi, I think I'm unmuted now. Okay, well, I'm very pleased to be here and that this webinar is happening because there was no more important experience in my professional career and actually in my life, really, than having the death of, well, it's more than one patient by suicide, and I'll tell you a bit about what happened to me. But I will say over my career, my professional career, I've probably had around 10 patients die in this way. And I think it very much depends your experience of how how often that happens, I think, depends very much on where you're working. So I was working in adult psychiatry in London. So I got my first consultant job in 2008, and I was so pleased to get it. It was a competitive job. I got it in a trust that I was trained in. It felt like home to me, amongst colleagues that were friends as well. And I arrived on the ward. And actually, at that time, it was just the start of all the changes, the bed reductions. And I arrived on the ward to be told that the unit that I was working in was going to close. And did I know that? So that was sort of already a prime sort of introduction to being a consultant at that time. But in my second week as a ward consultant, I found out my first patient. And it's interesting with this, you claim these deaths to yourself. My patient, mine, the first of the patients that I've been working with, and who I had discharged from the ward, died by suicide. And then that was in my second week, and then in my third week, another patient died by suicide. And I find it, even now, and I've talked about this a lot since then because it's defined my life, I find it very difficult to put into words the utter feeling of some part of me being annihilated. If I thought I was going to bring something healthy, help people, bring, help move them towards something constructive, in that 3-week period, that was absolutely, my belief in that was absolutely obliterated. And instead I felt I was toxic, that I had something wrong with me, that it was my fault. I found it very difficult to be with my family. I had 2 young children at the time and found it very difficult to be with them because I felt that they would sort of feel this toxicity, that I was actually dangerous for them. And I felt also, I felt humiliated and ashamed. I felt my colleagues who had just given me the job were looking at me and thinking, what did we do here? Who have we employed here? But also there was a very profound disconnect between my internal and my external. I carried on working because somehow in the doctor's psyche, you don't stop working ever. But inside I was in a state of abject terror with every patient that I saw. With coming into work, I dreaded it. And it's only looking back in it, I can see that I was suffering with post-traumatic stress. Every time the woman that had been dealing with serious incidents in the trust called me, if I ever heard her name, I'd have a panic attack. And this was also compounded by about 8 months later, we had another inpatient suicide on one of the wards. And again, so going to the coroner's court 3 times, having 3 serious incident inquiries in my first year. And so what happened at that point, it was in 2008 and hardly anybody talked about suicide, and they certainly didn't talk about the impact of suicide on clinicians. It was sort of hushed up by colleagues. So trying to talk about it was very difficult, but I was lucky enough at that time to bump into 2 colleagues who were going through very similar experiences. One consultant who'd had about 6 deaths in a short period of time, and another one that had 4. And what we decided to do was get together and form a reflective group just between us, and we asked Rob Hale, who was the director of the Portman, to come and join us. And for the next year we met on a monthly basis and we talked through these deaths, and from a place where I felt like I was drowning, and that I wanted to leave, and I couldn't believe that this career and profession that I'd been seeking and loved up until that point, I wanted to run away from. Gradually over the next year, I started to feel better. It was a bit like being underwater, and then the water level goes down and you realise you're actually on firm ground and you're still alive. So gradually over that year, I started to come back together again, but not in the same way, in a very different way. And ever since that time, in that year, I also thought, and in the way that Guy's saying, I think I had probably quite a profound spiritual crisis during that year, and thought actually that there's something about suicide that's the heart of human experience. And since that time, I've been helping my own trauma, which is still there, by working on suicide and trying to understand it and to work on the impact on clinicians. Because if you go through this, when you realise the profound impact it has on you, you can't believe that this isn't something that's not talked about. And when you start talking about it, people come up and they start talking about their trauma, but it's a huge area of unacknowledged trauma below the surface within, well, certainly the whole of mental health services. I mean, it's certainly, I've worked with GPs, and you actually, I think it's probably under the surface in general practice as well. And if I reflect on it, it's something that I thought about actually all day, every day while working in mental health. I left the NHS in 2018, and I think in part, I'd been there for another 10 years and had many more experiences. And I think at that time, I thought I probably had enough. I can't live with the fear of going back into that place again. Yet also, it's sort of defined a lot of creativity for me as well. So I'm coming to my time boundary, but also just wanting to say, look, this is a hugely profoundly important area, and the needs of all staff, of every individual clinician when this happens, will be very individual. And I hope, and Alison's going to talk about the research that we've been doing on this, and what staff say that they want and what clinicians say that they want after an event of this nature. So I'll move on to Alison.
Thanks, Rachel. So I'm representing a group of people of whom Rachel is a part, as is Karen Lascelles, Professor Keith Horton, who presented last week, and I think has done some of the other webinars, and a few others who will be listed at the end. We've been keen to investigate what the impact is for members of staff who experience the death of a patient by suicide, and also what would they want by way of support in those circumstances. What do they need? What are the needs, both professionally and personally, for those staff? So that's the research that we've been doing. Next slide, please. So the rationale, I think, has been very clearly articulated by Guy and by Rachel already, that the limited literature that's out there makes it very clear, and of course our personal experiences make it clear that it's very distressing for clinicians to experience the death of a patient by suicide. There isn't a lot of research into this area, really, relatively speaking, and our experience of offering support to staff, it suggests that not only is there an effect on emotional well-being in clinical practice, but actually there's quite limited resources out there for helping people and supporting them, and that we're not that clear about what it is that would be helpful. So we wanted to find out more about that, particularly that latter agenda, really. What would people want in an ideal world? Next slide, please. Next slide, please. So we had a couple of research questions, really. How does the patient suicide affect the emotional well-being in clinical practice for, firstly, psychiatrists and then mental health professionals? I say firstly psychiatrists because we've carried out two surveys, which I'll describe shortly. And then what resources would people like, would find helpful before and after the suicide of a patient? Next slide. So, as I say, we've carried out two internet-based surveys sent out by clinical leads. Some of you may have seen this, some of you may be people who responded to these surveys. Both of them have happened in this trust. The first one was focused on psychiatrists and psychiatrists in this trust and in Barnet and Enfield and Haringey Trust in 2019. And then secondly, looking at everyone else who's not a medic, not a doctor, and that was carried out in this trust. Next slide, please. And the questions focused or asked the participants to focus on the suicide which had had the greatest effect on them as a clinician. So thinking about their personal impact on their clinical practice, what actually was helpful and what was unhelpful regarding the support that they received. What was their experience of the formal processes following the death, so the inquest, the serious incident review and so on, and any suggestions that people had for what they would want by way of resources and other help. Next slide, please. So just to give you an idea of who responded, so for the psychiatrists, we had 174 responses, mainly from psychiatrists working in general adult settings, mainly consultants and mainly older consultants. Next slide, please. And for the non-medical professionals, they were mostly nurses working again in general adult settings. Most people very experienced, so having more than 10 years experience of working in mental health, and mainly women. And most of these people were working in community settings, so general adult community settings. Next slide, please. So most people had experience between 1 and 5 deaths of patient by suicide, but some people had experienced more than 10, so a lot. And for most staff in the non-medical group, these were deaths that happened in the community, perhaps reflecting where they're working now. Next slide, please. So in terms of emotional impact, almost everyone rated this as being a very significant experience for them, as you would expect. So 92% of doctors, 83% of other staff. Despite that, to reflect what Rachel was saying before, actually very few people took any time off work following this experience, or if they did, they took minimal time off. And particularly the psychiatrist group, only 3.5% of them took any time off work after the event. There were really strong feelings of being responsible, so particularly at the time, and this was pretty much universal across all of the professional groups. Lots of questions about what could I have done differently, lots of rumination, lots of worry about what they'd done, what they hadn't done, going over things, going over the story and the last contact with the patient frequently. It might be, and we're not sure about this because it wasn't really the focus of what we were doing, but that there are some differences across the professional groups regarding how strongly this sense of responsibility is felt. And that was probably something that we'd want to look at a bit more closely, or that other researchers perhaps could do. Almost universally, this sense of responsibility for the death decreased over time, and within about 2 years, for most people that was back down to manageable or negligible levels, but not for everyone. For some people this was an ongoing sense that they had some important part to play in the death of the patient. Next slide, please. In terms of other effects on clinical practice, perhaps because of this sense of guilt and responsibility, many clinicians, most clinicians reported a detrimental effect on their clinical confidence following the death by suicide. And in the psychiatrist group, that was most strongly felt by women rather than men. There weren't any differences in the non-medical group. And that does reflect some of the early research. The effects were, as I was saying, long-lasting for some people, ongoing even many years later. There were particular anxieties around competence to assess risk, and fears of further deaths by suicide, with people sometimes avoiding, if they could, working with people who were actively suicidal for fear of making errors, overlooking things, or having a similar experience again. For some clinicians, though, they were able to recognise that there was some professional growth to come out of these experiences for them, perhaps more as a longer term outcome. So having a greater sensitivity clinically towards their patients, maybe having invested in training or developing their skills around note keeping, around risk assessment and so on as a result of their experience. But also there's something about a kind of recalibration perhaps around responsibility and personal vulnerability in the context of the work that they're doing. Next slide. And this just kind of summarises the themes around the impact professionally and personally for people. So I should have said that we collected both numerical and qualitative data, and the qualitative data was particularly rich, and these were some of the themes that came out of it. Next slide, please. For many people, the experience of patient suicide had an impact on their career, and amongst the psychiatrists, nearly 40% of the senior doctors who responded had switched specialty as a result of what had happened, so away from the specialty where the impactful suicide had occurred for them. And it seems that experiences during training were particularly significant for people in terms of their career choices, their future career choices. There were a number of people who also who were in the older group who made comments about wanting to hasten their retirement or making decisions about leaving sooner than they might otherwise have done. Next slide, please. In terms of the non-medical clinicians, there were about a third of people who said they'd consider changing their career path as a result of their experiences, which is not as high for the psychiatrist group, but still quite significant. Most people were still working in the same area now as where the suicide had happened. Next slide, please. So what helped and what didn't help? Here's the table that describes a summary of what the psychiatrist told us. So for most people, support from colleagues, often people who've been through similar experiences, were particularly helpful and significant. But also other things too, so being able to engage with the families of the deceased, if they had the sense that they weren't blamed by them, but were able to engage in a meaningful and helpful way. What didn't help, the serious incident process was often perceived to be quite insensitive, and the word persecutory is used here, and I think that would be a fair summary of the sort of the flavour of some of the feedback that we received. So that wasn't true of everyone, but for some people that was very significant. And likewise, the coroner's court experience for some of these doctors. And for some, a small proportion of people, some of the interactions with family had been unhelpful and made things worse for the clinician. And I think it's really important to note that for some people, they felt nothing was helpful. There was nothing really available to them, perhaps, or nothing that was offered to them that made a significant dent in how they were feeling and improved things for them. Next slide, please. In terms of the non-medical group, we asked what help had been accessed and what had been helpful. Again, there's quite a group of people who didn't really access anything or didn't find anything that they accessed particularly helpful. But there's a strong theme again of the importance of the team, of team working. The most significant support seems to have come from managers, from colleagues, particularly colleagues in the same profession, and informal rather than formal support networks. It was important to people that they had good support from their managers, and in many cases they had very good experiences of support from management. And having reflective spaces, so places where there is an opportunity and an expectation that people can talk about their experiences, and for that to be an okay thing to do. What's not helpful? Well, one of the main things was about how the person found out about the death. So sometimes this seems to have been handled quite insensitively. So particularly perhaps people on the fringes of being involved with a patient may not have found out about that directly, but rather found out indirectly about the loss. And those sorts of factors seem to have contributed to the impact for the individual where that has happened. People commented on debriefing experiences that they'd had, sometimes that they weren't at the right time for them, or they didn't feel that they'd been particularly helpful. There were an equal, probably, number of people who found those sorts of opportunities helpful, And I suppose it kind of underlines the point that there were quite polarised responses to lots of the sort of offers of help that people had had, and that basically no one size fits all. And there may be issues here about the choices that people have. So there need to be things available, but people perhaps need to be able to exercise choice over when they use them and what they use, because different things are going to help different people. There was lots of comment about the formal processes and the investigations around the death and how often they were perceived, again, as the doctors told us, as being persecutory and difficult, and that people felt really unprepared for them. And finally, a lack of recognition that the emotional impact, well, I guess that there is an emotional impact for staff, but also that this can carry on for the longer term. So a number of people commented on help being available in the short and immediate term following a death, but that actually for them, the impact continued for a longer period of time, sometimes for a very long time, and that there might be a lack of recognition of that in the workplace, making it more difficult for them to manage that and to seek appropriate help. Next slide, please. So what would they have wanted? Interestingly, both groups prioritised the same items. So we provided people with a checklist and gave them the opportunity to check any of the things that they think might have been helpful to them with their experience. And there was almost an exact overlap in terms of the ranking of the top seven items happened to be exactly the same in slightly different order for both groups. So there's a mixture of things here, things like things involving emotional support, personal debrief, for example, but also help with the practical processes, help and information and guidance with the processes around managing the death by suicide within the organisation. Next step, please. Next slide, please. Thank you. So, as always, we've learned a lot from the research, but there's a lot more to be learned and understood about this. So there are a few questions that the data raises. One is about whether there may be differences as much as there are similarities between professional groups. So it's clear that there's an impact across all the groups, but it might be that there are subtle differences between them. There might be differences, particularly in the areas of perceived responsibility, and also the kind of support that people want might vary according to professional group, as much as it varies according to personal preferences. What does optimal support look like and what's effective? I don't think we really know the answer to those questions yet, so there's a lot more work that could be done in understanding that. And a lot of the research has been conducted in our own trust. Is this trust representative of all services? I think Rachel would say probably not. So as someone from outside of this trust, so we do have a suicide prevention lead in the form of Karen. We do have quite a sort of good awareness of some of the issues around this area, and that might not be true for all other services. So some of the responses may be skewed by that experience of working in Oxford Health. And we had a relatively low response rate, particularly for the second survey amongst non-medical professionals. It wasn't helped by the survey being launched a matter of weeks before the first lockdown in the COVID pandemic, so people's minds were elsewhere, I think. But again, that might call into question some of the generalisability of results that we have obtained. Next slide, please. So conclusion so far. We know that patient suicides have a major impact on staff, well-being and clinical practice, and that these effects can be long-lasting. For some, this can lead to a loss of confidence as a clinician, career change, or even leaving the profession. And for others, this leads to learning and positive changes in practice. how the aftermath is managed may influence these outcomes, particularly around the areas of how the person finds out, the support that's offered, and the preparation before the experience of a patient's suicide for some of the formal processes involved. Next slide, please. So one of the outcomes of our research has been a resource booklet. This is one of the reasons that we wanted to do the research in the first place, to find out what people would find useful and then to create a resource. So this is the resource that's specifically for psychiatrists, that's now freely available on the Royal College website, and we have hard copies as well. I think there's going to be a link put in the chat if you want to go and have a look at the content. It covers a number of areas around normalising people's responses from what we know from the research, how best to look after yourself, how to support others, dealing with the formal processes, and what others have found helpful. And there's lots and lots of ideas for sourcing support at the end of the booklet. And the first survey's been published now as a research paper. The reference is there if you want to follow that up. Next slide, please. So next steps, there's clearly a need for good quality information and for sources of support to be readily available for clinicians who have this experience. We're going to produce a second booklet that's focused on non-medical staff, and we're working on that at the moment. There's a group of people involved in providing guidance for trusts in dealing in supporting staff who've experienced patient suicide. Karen's involved in that, as is Rachel, so it's, and others. It's a multidisciplinary advisory group. And then it's clear that there are considerable training needs if people are to be better prepared for these experiences. So we need to be thinking about the roles of the professional bodies and also training programmes in that regard. And final slide, please. So just want to say thank you for everyone who has shared their personal experiences of patient suicide with us, to help us to understand better what is that like and what might help you. And thanks to the research group and the two trusts involved in doing the surveys. Thank you.
Thank you so much, Alison, and thank you, Rachel. An extraordinary piece of work that's been done recently, created by Alison and colleagues, in terms of the research and the survey. But Rachel, thank you so much too for something about, for me, what I took from your reflection was that, since yes, we all claim, you know, we talk about our patients, this kind of ownership, which equates to a real responsibility, doesn't it, in terms of that sense of the impact of feeling some part of us is taken away from us because we have that kind of responsibility. I was struck too by that sense in which, you know, having been underwater, then we, you know, that period of time when we're kind of sunk into the water and then eventually come out alive. But a profoundly important experience. Thank you. And to Alison too for the extraordinary amount of work that's really gone into that, into the publications and the survey. It is interesting, isn't it? There's no one response that fits everybody, and that's perhaps the biggest challenge for us all, as to how we need to tailor our support to each individual, and how we take real serious account of the long-lasting effects on us all. Find those reflective spaces. Still a bit disturbing that still we haven't got it right in so many areas where we're not putting staff at the right time, at the right place perhaps. But thank you both very much indeed, and thank you for those resources, of which I know they will be links made available for us to look at. So I'll hand over now to Karen to take over for the questions and answers.
Thank you, Guy, and thank you, Rachel and Alison, for your excellent presentations. You know, help us sort of gain an understanding of the lived experience from Rachel, and also that broader understanding from the survey that we've carried out. And I know from my involvement in it, the research group is made up of people very passionate about suicide prevention and supporting families and supporting staff. All of us have our own experiences of a patient dying by suicide, and some of us working with families and staff. And certainly from my perspective, much of what came from those surveys really resonated with my experiences. And it's helpful, like Rachel was saying, this sort of stuff really drives us, I think, to want to continue to work to get it right, so that we do support our staff in a way that is helpful. There are a couple of questions. The first one here, it's interesting that it was mostly older, more experienced doctors and consultants that responded to the survey. I guess this is from the medical side. I know that the junior doctor body has a lot of thoughts about the way in which they are informed about patient suicide, and a lot of not great experiences and how they're supported afterwards. Do you know why there was so little doctor feedback? I think it's really important. I know there is research out there, isn't there, that does look at the junior doctor experience. But Rachel, I wondered if I could pass this one on to you as in your psychiatrist role.
Well, I was thinking we actually looked at in the research, and the feedback was representative of the numbers within the trust. So we did have junior doctors, we had the doctors of different stages, but there just weren't as many as there were of the senior doctors within the trust. So I think certainly in the Barnet, Enfield and Haringey part of the trust, what was the very important thing there was those that had the death by suicide in their training were just not working in those areas anymore. Nearly all of them weren't working where they'd had the deaths. Yeah, I suppose that's what I'd say about that, really. And I was just thinking, everywhere I go, you know, I do a lot of talks on suicide and the effect of suicide on clinicians, and I'll usually ask the clinical audience how many of them have had a death by suicide, including trainees. I do a lot of talks to trainees of all sorts, and it's usually 2/3 that will put up their hands, both personal and professional experience. And often the trainees are often quite profoundly wounded if they have them very early on, and often can feel very, very abandoned. So I think the particular pastoral care in those that are training is very important. Thanks,
Rachel. Guy, did you want to add anything? Because I know from a trust perspective, this is something that we've realised, isn't it? That something that we need to improve on, how we communicate with junior doctors who've perhaps left teams. And I don't know if there's anything to add.
Yes, we do. I mean, we need to do more, that's for sure, in terms of making sure that junior doctors are involved. And often when someone moves on to the next part of their training,